Our next paper is a French registry of 189 cases of immune congenital heart block, maternal data analysis by Dr. Levesque et al. From France.
Ladies and gentlemen, buenas tardes. I'm here to present to you the Maternal data analysis from the French Registry of Immune Congenital Heart Block on behalf of the Lupus Neonatal Group led by Nathalie Costedoa-Chalumeau. I have no disclosure to report. We know that neonatal lupus is caused by the passive transplacental passage of maternal anti-SSA or anti-SSB antibodies. They have multiple manifestations, such as cardiac manifestations that include congenital heart block, endocardial fibroelastosis, and dilated cardiomyopathy. The incidence of CHB is around 1 on 11,000 deliveries. Women positive for anti-SSA antibodies have a 1 to 2% risk of having a fetus or a child affected by a CHB. The recurrence risk of CHB is around 17 to 21%, but we now know from an international study that the French registry was part of, and the English registry as well, and was led by Gilles Bayen, that with hydroxychloroquine, the recurrence rate is around 7.5%. So the objective of our study was to evaluate the risk of the mothers of fetus or child with CHB to develop an autoimmune disease over a long follow-up period. So we did a multicentric retrospective study, and with the help of cardiopediatrician and internists, we included most of the French mothers with anti-SSA and or anti-SSB antibodies who had at least one fetus or child with advanced CHB. So in this analysis, we had 172 mothers who had a total of 189 fetuses or children with CHB, and most of the CHB were complete, and most were diagnosed in utero at the median term of 22 weeks of gestation. The mean maternal age at the time of the CHB diagnosis was 29.4 years, and the majority of the mothers were of European origin. If we compare from the French population, we can see that we have a higher rate of mothers from North Africa. All our patients except one were anti-SSA positive, and the one that was not was anti-SSB positive. So all our patients were either anti-SSA or anti-SSB positive. So to know if the mothers were diagnosed with the autoimmune disease at the time of the pregnancy with the CHB, we call all the mothers and look at their chart, and we had a result of 73.8% of the mothers that were asymptomatic at the time of their first pregnancy with CHB, and the rest of them either had SLE or Sjogren's syndrome or UCTDs, and we had some rheumatoid arthritis, autoimmune hepatitis, idiopathic thrombocytopenic purpura, and systemic scleroderma. Our lupus patient had mostly cutaneous and articular manifestation, and 6 on 18 patients with SLE had in the past more severe manifestations such as lupus nephritis, pericarditis, neurological or hematological manifestation, and only one of those mothers had received cyclophosphamide. So at the end of our follow-up period of a median of 5.9 years, we asked the mothers if they now had symptoms of autoimmune disease or had a diagnosis of autoimmune disease. And from the 74% that we had before the first pregnancy with CHB, we now had a percentage of 37.8% of mothers asymptomatic. So we had a lot of women were diagnosed with Sjogren's syndrome or SLE or UCTD, and we had also a woman who developed a primary antiphospholipid syndrome. If we compare ourselves to other registry, we see that we are very similar to the European registry on the rate of asymptomatic patient or UCTD patient, but if we compare ourselves to the American registry, they had a lower rate of asymptomatic UCTD patients and a higher rate of Sjogren's syndrome. So in conclusion, at the time of diagnosis of CHB, a third of the mothers had a diagnosis of autoimmune disease. During the follow-up period, another third were diagnosed with an autoimmune disease, and the remaining third remained asymptomatic during a median follow-up period of 5.9 years. Patients who had a fetus or child with CHB should be followed afterward because of the possibility to develop an autoimmune disease. So I would like to thank all the cardiopediatricians and internists, as well as the mother and children that helped me do this study. And I would like to thank you all for your attention.
Thank you, Dr. Levesque. Now the paper is open for questions.
So let me start by saying, how thorough was the evaluation of the mothers during the pregnancy to be sure they didn't have? I mean, because you're quoting a very high rate of asymptomatic mothers. So the question is, how hard were they really evaluated to look for a connective tissue disease or autoimmune disease?
But that was a retrospective study, so we had only the chart and the memory of the mothers to know if they were really asymptomatic before the diagnosis of their first CHB. So we documented well, but we have that rate. So
over there.
Was there any difference between the diseases developed between the European mothers and the North African mothers?
Oh, I'm sorry, I don't have that, your answer here. Sorry.
Along those lines, your patients, you had 60% European, about 20% North African, so you're missing another 20%. Where are they from?
Oh, they were from many places, from Africa, and you know that France includes a lot of territories, so we had some patients that were mothers that came from there, like Polynesia, you know, all the territories, yes.
Thank you.
Let me ask you one thing. Do you have any data about the differential types of anti-Rho antibodies, if you have differences between those patients who develop any connective disease or not?
Since our registry, our first pregnancy in our registry is from 1975, I think. So we don't have that kind of information in the file that we get. In the new pregnancies, we have some pregnancy have the total assay for the NTSSA as 52 or 60, but most of the pregnancy we don't have, so we didn't try to evaluate this data.
Okay, thank you very much, Dr. Levesque.